Thank you, John, for really a wonderful integrated overview that I think is an extremely helpful conceptual perspective that we need to think about and can guide us, I think, in very important ways. Let's move on at this point to our second plenary presentation this morning from Professor Kate Davidson. Dr. Davidson is a fellow of the British Psychological Society, and as I mentioned earlier, a graduate of the University of Edinburgh, where she completed her training, and she's currently director of the Glasgow Institute of Psychosomatic Interventions. She also is editor of Personality and Mental Health and past president of the British and Irish Group for the Study of Personality Disorder, which has an acronym that is wonderful called the BIG SPD. She has developed cognitive behavior therapy for work with patients with borderline personality disorder and antisocial personality disorder, and works in both community and forensic settings. I had the pleasure of being in the audience and participating in her pre-Congress workshop, which was really a wonderful chance to, with relaxed amount of time, tune in to the nature of the work that we have really a lot of appreciation to Dr. Davidson for. She's going to talk to us about the third wave in a sea of treatment for personality disorder. Dr. Davidson.
Thank you very much for that very nice introduction. And I should say, good morning. And thank you to the organising committee, to Eric and to yourselves and the various others in the room for inviting all of us here to Copenhagen. And, I appreciate it hugely, and it's such a beautiful city. Now, I just want to say something about Dr. Oldham, if I may. I don't really know him very well, but I've got to know him in a very interesting way. He knew Peggy Sue. Do you remember Buddy Holly, anyone who sang Peggy Sue? I won't sing it because, well, it's too early, really. But there you go. Fascinating. I know some other things about you too that are a lot more erudite than that. So I'm going to talk to you this morning with a title that Eric sort of gave me. He said, can you talk about the third wave? And I thought about that and thought, well, is there a third wave, really, for personality disorders? And I'm not terribly sure about that. But I'm going to actually make us think a little bit about what's happened in some other areas. I'm going to talk to you a bit about therapy for borderline personality disorders, and some reasons, I think, to be pleased, to think we're going in the right direction. I'm also going to talk to you a bit about some reasons to be concerned. And in particular, I'm going to talk to you about how we put our evidence base into practice and how we improve what we actually do in therapy, because there's a problem here. And I'm going to borrow really from cognitive therapy, which actually has probably the most established evidence base for mental disorders. And we have a third wave in cognitive therapy that I think is problematic. And I'm going to talk to you a bit about that. And I'm going to really give you a bit of a health warning, I think. So that'll be interesting. So I'm going to actually then come back again into our area and think about some new insights that we may have about previous research that we've done. So I'm actually going to mine some data a little bit and think about how we could improve some of our practice-based therapy outcomes. So come with me on the journey. So the good news is we do have effective therapies, at least for borderline personality disorder. And I think all of you are well aware of that data, and it appears in many clinical guidelines. For example, recently, no, I want to go back one. I've changed the order of my slides. How interesting. What I'm going to talk about then is why we have effective therapies and what might underpin some of the relatively good outcomes that we get in psychological therapies. And I'm borrowing from Dr. Livesley. John will talk about, when he talks about therapy and therapeutic approaches, John will talk about why these individuals have the problems that they do. And one of the things that they often have in common is the childhood adversity that they faced. And this, I think, then, has implications for therapy. They tend to have had environments that are threatening. Also, they tend to have been brought up in environments that could be characterised as being chaotic, and in which they have felt powerless to be able to have any kind of control over. Marshall Linehan, I think, got it absolutely right in saying that their environments have often been invalidating in terms of their emotional experience. They've been told that their own experience is somehow either not worth noting or is somehow misplaced. And these characteristics of their early environments and how they've experienced interpersonal relationships are actually quite important for thinking about what might underpin effective psychological therapies. Some therapies may have all of these factors and others may just have some. So, for example, if you've been brought up in an environment that is threatening, what might be important in therapy is obviously developing an empathic and trusting relationship with your therapist, but also that the therapist ensures that this environment is supportive and is safe, I think, for the patient to undertake therapy. And it's interesting what John was talking about, anxiety and the kind of cognitive mechanisms that are important, that perhaps at a later stage in therapy, people need to be able to evaluate the meaning of the threat. What is it that makes them anxious? If you've been brought up in an environment that is characterised by chaos, what you do need in therapy is some sort of consistency, both in terms of your relationship with the therapist, but also how the therapy is structured. If you've been brought up in an environment that you feel powerless to control, you may need some behavioural competencies. You may need, for example, to understand how to be more assertive with individuals. And Marshall Linehan again talked about the importance of validation as a technique in psychological therapy. So you can see if this is the childhood adversity, this straight away has implications for the sort of therapies that we might develop and the strands that need to be there in those therapies. So, recent Cochrane review said there are lots of effective therapies, particularly for borderline personality disorder. Dialectical behaviour therapy, mentalisation-based therapy, cognitive therapies, schema-focused therapy, transference-focused therapy. We're not short of therapies, and there have been, as you can see, a number of randomised controlled trials showing that they are all helpful in reducing individuals' problems. However, as you all know, structured clinical care is also helpful, and indeed there are no differences in outcome for dialectical behaviour therapy, mentalisation-based therapy, or CAT when you compare it with high quality structured clinical care. Now that may vary depending on the package, but nonetheless there might be some consistencies. And this has been found both in adults, and Andrew Channon's work in Australia was also found with adolescents. Now, one of the things that we've been doing in the UK is trying to think about how to train people in psychological therapies for individuals with personality disorder. But also we've been thinking about, well, what is structured clinical care? So what we've done is gone to all the manuals and actually tried to extract what are the components that we think might be useful in a very systematic way, actually so that we can then develop training courses across the UK. And we've done this in conjunction with people like Tony Roth and Steve Pilling in the University College London. And there's a number of you in the room, including Mary McMurran, and I think Sue Clark is somewhere. All of us have been involved, and Anthony Bateman, in doing this work. So it's really a very substantial piece of work that has been done. And you can go to the website and you can see what is there, and that would help inform, as I say, training courses. So let's just have a little look at what some of the essential elements in structured clinical care might be. Well, one of the things that we managed to pull out from all of these sort of manuals is that the staff who are providing that care need to be knowledgeable about personality disorder. So they have to have that background knowledge, but they also have to be able to communicate it clearly to patients. They have to be able to assess patients' problems and be able to give them some psychological understanding, what we call formulation, of their problems in a context, and actually probably in some sort of theoretical context, John. We also know that we have to actively involve clients in their own care. This is not a we do to them kind of psychological therapy. They have to be actively involved in their care. The therapeutic stance, what is that? Well, from what we can gather from the manuals, is that you are really helping the patient by being patient, by being compassionate about their problems, and being sensitive about their needs. And we need to take a consistently inquisitive and encouraging the client to be curious about how they think about their problems and how those problems develop and are maintained. So that kind of encouraging inquisitiveness and curiosity is going to be important. We also need to be humble. We need to accept that we won't always be able to fully understand the client's subjective experience, and actually to probably be open and honest about that with the client. It also includes structural things like you need to meet regularly, you probably need to have a psychological formulation, as I've said. You need to reinforce the client's positive coping skills. So notice when they do things that are helpful, and perhaps increase their problem-solving skills. And usually the focus has been here and now in terms of problems. Now, actually, structured clinical care may be effective, but because it includes the common factors across all effective psychological therapies. So we've extracted the useful things, and that's maybe why it is effective. So, we know that we have effective treatments. How do we do things actually better? How do we put this research into practice? Now, here's the bad news, at least for the UK. If you're a rather sad person like me, you sometimes go to the appendixes of big government documents and actually look at their data. Well, in England, and you can perhaps hear a bit of jealousy in my voice because it's only in England, not in Scotland, there have been millions of pounds spent on something called Increasing Access to Psychological Therapies, IAPT. And in IAPT, there have been trained hundreds and hundreds and hundreds of therapists in cognitive therapy to be able to improve the health of the nation and get people back to work. That's the economic model. And it is being relatively effective. And the second phase of this is actually developing IAPT for more complex psychological disorders. And this document came out which was kind of looking at that. So if I just look at this. So in our health system, and this is the UK, perhaps there are 15% of adults with anxiety and depression, of whom 24% are in some sort of treatment, and of whom about 10% in 2007 were receiving psychological therapy. Look down to psychosis. This is fantastic, I think. About 0.4% of people might have a diagnosis of psychosis of some sort. 80% are in treatment of some sort. And about 43% in the UK were receiving some form of psychological therapy. I think that is truly remarkable. And of course, if you look at the next line, personality disorder, there's a blank against the percentage receiving psychological therapy. Now, some of you in the room will say that's not true. We have services in the UK for people with borderline personality disorder, and you may do. But actually, even that is hardly registering across the country. And if you broaden it out to personality disorder per se, it's just not there. So we know we have these individuals in our services, but we are certainly not providing treatment. So actually, it's not good enough. And this document actually acknowledges that. So, what's the problem? Well, let me take you to a journey into cognitive therapy. But first of all, to say, we know it takes a long time to put research findings into practice. And in fact, it can take an average of 17 years to turn just 14% of original research findings into changes in care that benefit patients. Shall I go? What about cognitive therapy? How long has it actually taken us to implement cognitive behavioural therapy? And then I'm going to talk to you about a third wave. Well, behaviour therapy started way back in the 1950s with Walpy, with Ogden Lindsley, and with Eysenck in the UK in the early 1950s. I did my clinical training in the 1970s in Edinburgh, and we were very excited about something quite new called behaviour therapy. That's how long it took. And in fact, we called ourselves radical behaviourists in those days. And when I speak to Marcia Linehan, she also was trained in the era of radical behaviourism. But folks, it took a long time to get there, to actually get it implemented in terms of embedded in training. What about cognitive therapy? Well, it started, as you probably know, in the early 70s and sort of developed a bit in the 80s and indeed right to the 90s, where we had much more honed specific cognitive type treatments for specific disorders. So cognitive therapy for panic disorder is different from cognitive therapy for depression and is different from cognitive therapy for psychosis and so on and so forth. So we've continued to develop it. And there's a third wave coming: ACT, acceptance and commitment therapy. Mindfulness-based cognitive therapy has been starting since almost 1999, 2000 and onwards. Let me just put some historical events onto this. So cognitive therapy, around the time of the moon landing and Bowlby's maternal deprivation. Behaviour therapy, interestingly, around the time of Ash's experiments on conformity. And the Berlin Wall came down at the time that we were really developing CBT for more individual kinds of disorders. And Simon Baron-Cohen, Uta Frith were developing an understanding of theory of mind in autism. And the new third wave of therapies have happened when the euro was born, but also things like the Indian Ocean earthquake. But also, we now know that a third of us report hallucinations. There's something about normalizing abnormal, potentially, phenomena. So I think that's kind of quite helpful. I remember the Berlin Wall going up and I remember it going down. So these are events that get marked in one's mind. So what about the CBT story so far? Because as you can see, it actually started quite a long time ago. We have the strongest evidence base of all psychological therapies in terms of effectiveness. But there is now a third wave approaching, which has become, certainly in the UK, very popular. Is it popular in your areas too, in your parts of the world? Yes. Interesting. But they may not be more effective. Let's have a look. We have mindfulness-based stress reduction. That came from John Kabat-Zinn. We have mindfulness-based cognitive therapy, which came from Seagal and Mark Williams, and John Teasdale developed it, and Hayes, etc., acceptance and commitment therapy. And maybe dialectical behaviour therapy has a bit of the third wave in it too. Let me just go into a bit of background about why we developed things like mindfulness-based cognitive therapy, some of the background influences. Well, Mark Williams and John Teasdale noticed that there is a problem, of course, as many of you know, with depression. People do relapse. There's over 50% recurrence rate. And interestingly, of those who have a recurrence, if they've had previous suicidal thoughts, over 50% of people will have these suicidal thoughts again. And even we know mild mood can trigger a depressive constellation of thoughts, feelings, and sensations that may be a precursor, of course, to the relapse. We have experimental evidence that after recovery from depression, these biases in thinking occur in the presence of even mild mood. So mindfulness-based therapy, cognitive therapy, was developed. It's a very different technique. It has to help with this. Just one definition of mindfulness from John Kabat-Zinn. It's the awareness that emerges through paying attention on purpose in the present moment and non-judgmentally to the unfolding of experience moment by moment. So it's not buying into the interpretations, perhaps, the negative interpretations. It's just becoming an observer in the moment. Now, third wave cognitive therapy, there's different sort of philosophical routes, really, and I'm just going to make these a little bit larger. How do we understand suffering in cognitive therapy? Well, we see suffering as a sign of a disorder. As therapists, we want and feel we should reduce those problems and symptoms. We think we can learn to control our experience. We want to reduce or eliminate pain. And the strategy is quite combative and mastery focused. What mindfulness would suggest is that suffering is actually part of being human. Life has to be lived despite those problems and symptoms. And actually, trying to gain control is part of the problem. So the task really is to work around the pain so that it doesn't erode quality of life. And the strategy really is one of radical acceptance. It's very different. So the implications are that our evaluations are different or separate from our experiences. It's normal and okay to have unwanted thoughts and feelings. Observing our internal experiences alters our relationship to them and may help relieve suffering. We need to support clients to become better at living a rich and meaningful life. And this is the values-based aspect of the third wave in cognitive therapy. It's not just to get them becoming better at feeling good. We can pursue a meaningful direction independent of our internal distress and experiences. So it's actually conceptually very different from the original cognitive therapy. So, might that be potentially benefit to us in our area of personality disorders? Well, it would mean that thoughts, feelings, and experiences are actually more important than a diagnosis. It might normalize thoughts, feelings, and experiences rather than seeing them as abnormal. It would be experience rather than trait-orientated. And perhaps it could help our clients live more meaningful lives. However, it ain't any better than cognitive therapy. And you have to be careful of the emperor and his new clothes. Oost, who some of you will know because he's from your Nordic regions, in 2009 got into a bit of a fracas with Steve Hayes and others in the ACT business because he evaluated ACT and looked at the effect sizes. And in 2009, he said the effect size of ACT was 0.62. Since then, Stephen Hayes has sent him every single study that's been done on ACT. Well, you wouldn't expect anything other than Oost to then look at the effect sizes. And at a conference in London, he reported that there are now 65 randomized controlled trials, of which 50 you can actually examine. He had to exclude 15 because they weren't good enough to really look at this data. The effect size has now dropped to 0.49. And at follow-up, the effect size goes down again. So actually, rather than improving the evidence base or saying actually this is a helpful treatment if you look at it, it's actually got worse. Now, why has it got worse? Because I think they've been in a bit of a hurry. And it's not been evaluated as thoroughly as cognitive behaviour therapy. And the RCTs that are there are actually rather poor. They have poor research methodology. The majority of studies were underpowered. Only 4 out of 50, 8%, had adequate power. In terms of diagnosis, 42% of patients in all the studies were given some sort of diagnosis. 6% diagnosis just completely not known. And in 52% some sort of diagnosis, but it wasn't very clear how that was established. In 41 out of the 50 studies evaluated, the comparison was an active treatment. The therapist effects were unclear. There was only one therapist in 18 studies, so it could have just been the effect was due to that therapist. And in another 8 studies, there were only 2 therapists. So we've no idea how generalizable this is. The treatment adherence was unknown. It was only stated in 12 out of 50. So were they really giving ACT? We're not that sure. And the competence of therapists delivering ACT was only assessed in 9 out of 50 studies. So actually, they've done themselves a disservice, I would say, rather than a good service by rushing ahead. Now, I'm not saying ACT or the third wave may be helpful or may not be helpful. I think we don't know. And we shouldn't be in too much of a hurry to establish the evidence base. So folks, all that glitters and is shining and new and exciting, and everyone wants to go on the training courses, does come with a health warning. All that glitters is not gold. So be careful. And let me just follow this through a little bit for our area. Putting into practice, research into practice for personality disorders. If we're going to improve the way therapy is delivered in everyday practice, let's have a look at the evidence that we have so far. For example, there is some idea that you have to give quite intensive therapies in order to treat patients with personality disorder, particularly perhaps those that are more severe. I bet all of you believe that. Yes? So if patients are more severely personality disordered, they need more treatment. Anyone dissents from that view, please raise your hand. Thank you, Dr. Paris. 1 or 2? 3, 4, 5, 6. Okay, I would say, and Andrew Channon. Hello, Andrew, or you're just waving? So, actually very few of you. Can we just have a little look at this? Treatment duration. This is in the RCTs. Goes from 1 year to actually 3 years for schema-focused therapy and transference-focused therapy. And I know that some of it is delivered in a shorter time frame as well. DBT, roughly a year, CBT, roughly a year, MBT, roughly a year. But that's not the whole story, because actually some of these longer-term, more intensive therapies might be actually difficult to sustain, because if I was designing a service, I need the same therapist to deliver the therapy, because we know the therapeutic relationship is important. I'm going to tie them into delivering this treatment. Let me just have a little bit of a look at this. With a colleague, Kathy Tran, who's was my research assistant at the time. She's now doing her clinical training. And John, you've just published this paper, so thank you. We looked at, does intensity of therapy influence clinical outcome? And a priori, Kathy went away and did the kind of systematic literature review, pulled out the papers, and we said we want patients that are likely to be severe. So suicidal at entry into the study, and also where there was a measure of depression. Well, you know, this is really shocking. You'd think we'd be able to measure something like suicide attempts. Well, the 6 studies, 7 measures of suicide attempts. Luckily, in most of the studies, apart from one, most people used the Beck Depression Inventory. So all trials, patients met criteria for borderline personality disorder and had a recent suicidal episode before entering the trial. Then we divided the therapies into more or less intensive. More intensive was more than 100 hours. It ranged actually between 175 to 180 hours. And the therapies there were dialectical behaviour therapy, 180 182 hours over 52 weeks, and mentalization-based therapy, which we calculate at 175 hours over 70 weeks. The less intensive therapies range from 24 on average to 84 hours of therapy. And those were modified DBT and DBT of up to 80 hours over 104 weeks, and RCBT for personality disorders, which was 30 hours over a year. So you get the idea that actually there's quite a big difference in terms of therapy time and intensity. So let's take depression. These are the scores on the Beck Depression Inventory, apart from Linehan, it's got a star against it at the far, I think that's right, isn't it? So they're all in the Beck Depression Inventory, and you can see actually the patients are not the same. If I map onto that the levels of depression, you can see that our study actually, and I didn't know how this was going to come out, but our study in cognitive therapy for personality disorders, which is 30 hours over a year, actually had taken in the most extremely depressed patients. And mentalization-based therapy and Turner's DBT, moderately depressed. Shelley McMahon's DBT study was severely depressed patients. And also Marcia Linehan's study, if you translate that for the Hamilton rating scale, is severely depressed. So, we're not comparing the same things at all. These patients have different levels of depression. So what happens when you treat them? Well, the yellow bars represent end of treatment. They all drop by 13 to 15 points on the Beck Depression Inventory, exactly the same, regardless of whether it's hundreds of hours of treatment or just 30 hours of treatment. It's the same gain. I thought that was fascinating. Of course, some will go below the clinical cutoff for depression because they started off lower too. And if we look at the control groups, are they doing well? Well, actually, they all go down too. The control groups do pretty well, but they only drop, on average, almost exactly the same 11 points on the Beck Depression Inventory, or the equivalent in the Hamilton, apart from Turner, which was a very small study of only 12 patients in each group, so there was a problem there, and his control was very active. So in terms of depression, we weren't comparing the same types of patients. Some were much more severely depressed than others. Regardless of the intensity of treatment, they all dropped down 13 to 15 points. What about suicidal behaviour? Because that's a very important clinical outcome. Do we actually do anything for that? Well, actually, all the treatments help. It's either the same or they do a little bit better, regardless of intensity of treatment. We know that actually we can improve suicidal behaviour. Mood is a bit more difficult, actually, to change. So, more versus less intensive therapies? Well, different levels of severity of depression at baseline in trials actually make direct comparisons between therapies problematic, but it may not be what you think, is really what I'm trying to say. They all, regardless of intensity of therapy, reduce depression in a similar way, between 13 and 15 points. And as I say, only one trial of less intensive DBT reported a significant decrease in depression when you compare it to a control group, but that study was tiny, 12 patients. In all other studies, again, the control group also showed a decrease between 10 and 11 points. And regardless of the intensity of therapy, all reduce suicidal behaviour. We're interested in cost in the UK and cost efficiency, and I think most of you are too. This is just our 6-year follow-up after 30 sessions of CBT, and we costed out all the healthcare costs for individuals who had cognitive therapy. After the first 2 years, or 1 year of cognitive therapy plus 1 year follow-up, our CBT patients were costing on average £12,785. We followed them up over 6 years. Peter Tarner was involved with this. There was a London group. And after 6 years, they had maintained their gains, in fact, even improved on them. And the cost to the health service had reduced by half. If you compare that to treatment as usual, the costs were more, a third more at the beginning, 18,000, and at the end they were still at that level. So actually even brief psychological treatments not only improves patients' problems, but actually can also reduce costs. However, there still are problems, in that what is adapted from research may not be used in the same way in routine clinical practice, and therefore we may not be getting the same outcomes. Let me just talk to you a little bit, again from the world of cognitive therapy, about therapists' effects. And you can see that therapists ranked from most to least effective vary. That's not a surprise. But what is really important is that those therapists have different recovery rates in their patients. These are 119 therapists treating over 10,700 patients. And the therapists could be divided into 3 groups, depending on the clinically significant change that they achieve with their patients. In the yellow category, which are people that had excellent recovery, there are only 21 of those therapists in that group. In the poor category, there's 19 therapists, and most people were average. If I ask you, are you an excellent therapist? Are you above average? I think most of you would say, yeah, I'm above average. Wouldn't you? You don't think you're average, do you? No. Here's the bad news. We looked at mental health professionals, compared their overall clinical skills and performance to others in their profession. When you ask people to rate themselves, the blue line, almost everyone says they're above average. There's a few people that say they're excellent. When you actually look at their skills, most people are average rather than above average. And indeed, there's a few that are poor. And very few people are actually excellent when it comes to it. We delude ourselves in thinking that we're definitely above average. And the implications are this. They are serious. When you look at therapist effects and differences, they're not due to the type of therapy, they're not due to the therapist's qualifications, or actually training, interestingly. It's not the duration of the therapist's experience, it's not their age, unfortunately, it doesn't always come with wisdom, and it's not their gender. We looked at the influence of therapist competence and the quantity of cognitive therapy that people got on suicidal outcome and also inpatient hospitalizations in our borderline study in cognitive therapy. This has just been published this year. We had 106 patients with borderline personality disorder, all of whom had made a suicidal attempt at entry into the study or had been inpatients. And so this based in community clinics in the UK. And we examined the impact of the quantity of therapy and the quality of therapy on a hard outcome, one that we knew that we would be able to get with some degree of reliability and be able to check and verify. So we chose suicidal acts. John Norrie is our statistician, and a clever man he is, because I'm not going to describe the analysis other than just tell you what it was. So what did we do? In the trial, for those that were in the cognitive therapy arm, we had audio taped all their clinical sessions, and two individuals, Andrew Gumley, in fact myself, listened to the tapes, an average of 3 tapes per person for different patients. So one patient would have 3 tapes, maybe from the middle, the beginning, and towards the end of therapy. And so we knew how competent that therapist was with that individual and all the individuals, if you like, that they saw in the trial. It was very, very time consuming, I have to say. I had to do lots of cooking in my kitchen at the same time as listening to the tapes, because it starts to drive you slightly mad. But nonetheless, we did the ratings independently and tried to get a score for each of the therapists in terms of how competent they were. Then the clever statistician developed a way of actually looking at estimating the treatment effect of treatment when it's actually received. It's called case analysis, and it's been developed by big grants from the Medical Research Council, and John Dunn is the statistician really involved in doing this kind of analysis. And so we looked at the effect of treatment by competent therapists. Well, if you get cognitive therapy and you get at least a dose of it, so it's at least 15 sessions, a competent therapist will avert 5 times more suicidal acts compared to the least competent. It really matters. It makes a difference. Now, I think this is very, very important, because it means it's not just the kind of therapy, it's the degree to which you actually are competent at delivering the therapy. So, if we're going to change clinical practice, I think the service is still not good enough for personality disorder, at least in my neck of the woods. Why not offer good structured therapy or good clinical management? But in order for it to have no loss of effectiveness, it still needs to be delivered skillfully. We need to understand that therapists are more or less competent, and maybe supervision might help us to modify the poor response to therapy of patients, if we're monitoring clinical outcomes. So if we're going to put evidence-based practice into practice-based evidence, we probably do need training and supervision. We need to monitor these clinical outcomes and perhaps give people the feedback to say, actually, you're not doing as well as you think you are. And I think we also need to gather some cost efficiency data. And these are the beautiful cloisters of Glasgow University to say thank you for inviting me.